Welcome to the lecture entitled Anatomical Cross-Sections of the Thorax Made Easy. My name is Carlos Andres Suarez-Quian. I am the author and narrator of this presentation. Let's begin. There are three main objectives in this lecture. First, I will demonstrate the anatomy of the mediastinum as it appears in coronal planes, traveling from an anterior to a posterior direction. Second, I will demonstrate the mediastinal anatomy in cadaveric cross-sections. Finally, I will relate the structures in the cadaveric cross-sections to CT images. Ultimately, it is CT images and MRI images that most clinicians will see of their patients that will lead to their correct diagnosis afflicting their patients. Let's start with a simple question. Do we really need to know gross anatomy in cross-sections? The simple answer is no. So why bother to even learn the anatomy in this fashion? And now the answer becomes somewhat more complicated. Development of CT and MRI imaging technology made it necessary for physicians to become familiar with the content of the body as viewed in horizontal cross-sections or axial views, as these images are referred to in the literature. Thus, presenting the anatomy in cross-section is simply intended to help you identify what you will see in CT and MRI images. Ultimately, however, competent clinicians develop the ability to discern structures in any plane. However, understanding the anatomical structures in axial views is made easier if one first reviews the structures as they appear in coronal planes. That is, the clinician must be able to identify structures as they appear from superficial to deep in their transverse orientation, precisely as we dissect the cadaver. Below, a brief review of the mediastinum is presented, followed by a description of the different structures encountered in the mediastinum in an anterior to posterior direction to begin our appreciation of axial imaging. Recall that the mediastinum is divided into a superior and an inferior division at the transverse thoracic plane by an imaginary line that runs from the sternal angle, the angle of Louis, posteriorly to the intervertebral space between T4 and T5. The inferior division is further divided into an anterior, middle, and posterior compartments. Technically speaking, T3 and T4 make up the bony back of the superior mediastinum, but vertebrae T1 through T4 are commonly referred to as the posterior wall of the superior mediastinum. As to what can be found in each component that makes up the mediastinum, it is possible to make lists for study purposes to begin the process of learning how we will know what to look for in an area of the body as we gain experience. For example, here are the structures found in the superior versus the anterior inferior, the middle inferior, and the posterior inferior. And to my surprise, no one has ever asked me to recite these lists, as it is likely no one will ever ask you. The goals of generating lists are simply that in time, this information becomes part of your vernacular if you work on the thoracic cavity. And realize also that some structures are found in more than one compartment. For example, think of the esophagus. You will see it as both in the superior and inferior mediastinum. Thus, How to respond to the question of what is found in the superior mediastinum if the esophagus is not listed. This is the reason for why lists are just that, study devices. Think of them as guidelines to help you understand the material that is to come. But no one will ever ask you to recite what structures are found in the superior mediastinum, unless, of course, you pursue radiology as a career. Then all bets are off. But here's a clinical scenario. A patient comes in with trauma to the area of the superior mediastinum. Now, you must be ready to consider what structures are at risk of injury. Is it the airway or the digestive tract that you think about? It is these clinical scenarios that lead you to begin to appreciate the structures of importance present at one region and not the other. And yes, learning all this information takes time and dedication. One final note about the content of the thoracic compartment. The upper abdomen is contained within the lower half of the rib cage. It is inferior to the diaphragm at the T8-T9 level and anterior to the tail of the inferior mediastinum. Therefore, several lower ribs cover the upper abdomen. The importance of this relationship becomes apparent in cases of trauma. For example, a penetrating wound at the level of T11 can either cause a pneumothorax if it enters the thoracic cavity posteriorly, or an evisceration of bowel if it enters the abdominal cavity anteriorly. If you're to become a good clinician, then having X-ray vision would be an ideal talent. And this brings me to cross-sections. Years ago, when the subject of cross-sections would come up, students would suddenly gasp in horror, knowing that learning this material was going to be truly difficult. But universally, every student would question the necessity of knowing cross-section anatomy. What was the use? You'd never see patients in this fashion. Then, in 1971, Godfrey Hounsfield demonstrated that the body could be imaged cross-sectionally using CT technology, for which he was awarded the Nobel Prize in 1979. Clinicians immediately understood what a great tool CT imaging would be to diagnose living patients, and by the end of the decade, it seemed that the need to know cross-sectional anatomy was back, not because one would actually see cross-sections of patients, but because they could serve as guides to understanding the CT images that are presented as cross-sections or actual images. And yes, it does take some practice to know your anatomy this way. The first step needed to be taken was to reach some convention on how the cross-sections would be presented so that it could serve as a guide for the images generated by the CT devices. By convention, the images are viewed as if you're at the feet of the patient's bed and looking towards their head. The patient is lying down on their back, hence the anterior of the body will be projecting on top of the image. The back of the patient will be located on the bottom of the image. The right side of the body will be on the left side of the observer looking at the slide, and the left side will be on the right side of the image. You will need to develop the ability to think in mirror images. Forevermore, you will read any cross-section shown to you using this orientation, and by the way, this holds true for MRI as well. Finally, unlike a true body slice, a CT MRI slice has no width. Everything within the slice viewed is averaged to give one CT value. This is called the partial volume averaging. Thus, if a CT scan is done with large slices, say a sonometer, there is a greater chance that a lesion will be missed because everything in that centimeter slice is average. In contrast, a slice done at 2 millimeter is much less likely to miss a lesion, but there are so many more slices and thus much more time consuming for a radiologist to examine. The principal objective of this lecture, then, is to learn how to identify structures in CT cross-sections. Paradoxically, to become proficient at this, it is best to review the thorax as when you dissected it, from an anterior to a posterior direction, and to recognize coronal planes that we encounter as we proceed to enter the deeper structures of the cadaver. Here, for example, we have superimposed a bony thorax on a partially dissected cadaver. The sternal angle is indicated to distinguish the superior mediastinum from the inferior mediastinum. What do we see if we remove the sternum, costal cartilages, and anterior portions of the ribs? The pleural plane. Note the right and left sternal lines of pleural reflections. They come pretty close to one another just posterior to the sternum, and then the left one departs because of the heart, creating the bare area of the pericardium. As an aside, does this remind you of where to insert a needle to alleviate the symptoms of cardiac tamponade? If we retract the pleura laterally, we expose a fatty-looking extrapleural material, that is, the thymus in the adult. This plane is a downward extension of the glandular plane of the neck, and it is formed by the thymus gland, a primary lymphoid organ located in the lower part of the neck and anterior part of the superior mediastinum. During the embryonic life, the thymus is an organ of the neck, but in time it migrates down to become a structure of the superior mediastinum. After puberty, the thymus undergoes a gradual involution and becomes mainly replaced by fat. To continue exposing the structures found in the superior mediastinum, we must remove the thymus and accompanying fat. Deep to the glandular plane, we encounter the venous plane. In this dissection, the heart is in situ and most of the pericardium has been removed. The superior vena cava is clearly visible on the right side of the heart. The right and left brachiocephalic veins drain to the IVC and are also found in this plane. The remaining pericardium is now removed to expose the next plane. We have reached the arterial plane, where the ascending aorta becomes clearly visible. However, if we remove the veins, we can now clearly detect the arch of the aorta, which gives rise to three main branches: the brachiocephalic artery, the left common carotid, and the left subclavian. Finally, the pulmonary trunk is also visible. Remember, the pulmonary trunk is an artery because it takes blood away from the heart, albeit it is deoxygenated blood. If we cut through the pulmonary trunk, as was done in this heart, and the heart is reflected to the right, we now can gain an additional view of the arterial plane. Again, I show you the pulmonary trunk, but now the left pulmonary artery becomes apparent. By zooming in this area, we can see important structures of the superior mediastinum and label them: the ascending aorta and its arch, and the cut pulmonary trunk. And now identify the ligamentum arteriosum between the pulmonary trunk and the arch of the aorta. A prominent nerve is evident, the left vagus nerve, which gives off the left recurrent laryngeal nerve just posterior to the ligamentum arteriosum. The vagus then continues as the esophageal plexus. A second prominent nerve that can be observed is the left phrenic nerve. Understand, however, that the nerve is not truly at this plane. Its location here is simply an artifact of the dissection and the photographic capture of the nerve. Remember, the phrenic nerve runs in between the pleura and pericardium, anterior to the root of the lung. The final structures present at this plane are the lymph glands, and there are many of them. Sometimes they resemble a solid mass of tissue, as in this example. Reflecting the aorta and the IVC, we expose the trachea. We do observe another artifact of photography here, however, in that the esophagus appears to be at the same plane as the trachea. It is not. It is behind it. But what is very clear now is the left vagus, the left recurrent laryngeal nerve, and the esophageal plexus. The left recurrent travels lateral to the trachea on its way to the larynx. The trachea bifurcates into the two primary bronchi observed in the image. The bifurcation takes place at the level of the sternal angle. Indeed, realize that the venous, arterial, and tracheal planes all end on top of the pericardium, which forms a partial floor to the superior mediastinum, just anterior to the esophagus. You will see shortly why this piece of information is key in interpreting CT images. Next, we encounter the esophagus. The esophagus is considered the long axis of the mediastinum because it runs the entire length of it. It begins in the neck and is a direct continuation of the pharynx at the C6-C7 level, drops vertically through both the superior and inferior mediastina, traverses the diaphragm at the T10 level, and ends in the abdomen where it is continuous with the stomach. And yes, the esophagus is anatomically anterior to the descending aorta, although the depth of field misrepresents this fact sum in the image. The anterior disposition of the esophagus to the aorta can be more readily appreciated in a cadaver in which the heart is still present and only the lungs have been removed. In this image, the esophagus can be observed anterior to the descending aorta prior to just piercing the diaphragm, accompanied by the left vagal plexus, and just after it has entered the abdominal cavity. The esophagus, I repeat, pierces the diaphragm at the T10 level, whereas the aorta passes into the abdominal cavity posterior to the diaphragm at the T12 level. We will review this concept again when we study the retroperitoneal space in the abdomen. Looking at the esophagus from its right side, we can now see the anterior and posterior esophageal plexuses. Because the esophagus rotates to the right during development, the anterior esophageal plexus consists principally of contributions from the left vagus, whereas the right vagus is found mostly contributing to the posterior plexus. However, realize that once the plexuses enter the abdomen, it is not possible to discern the specific contribution of the right or left vagus to a particular nerve of the abdomen. Posterior to the esophagus, as is now indicated in the image, we observe the thoracic duct. The thoracic duct can be easily overlooked and torn during a cadaveric dissection. Here, it is colorized deep green to demonstrate its path. The thoracic duct forms at the sternochyli, located just to the right of the descending aorta, and travels into the thorax along with the aorta, posterior to the diaphragm. It conveys lymph from most of the body to the venous system. In fact, the only parts of the body that are not drained by the thoracic duct are the right half of the head and neck, the right upper limb, and the right half of the chest, which are drained by the right lymphatic duct. Removal of the esophagus exposes the path of the thoracic duct. At the level of the sternal angle, the thoracic duct will cross from its primary location of the right mediastinum to the left of the mediastinum. Ultimately, the thoracic duct exits the mediastinum and enters the neck. It will drain at the venous angle formed by the left subclavian and the left internal jugular veins. We will see this drainage when we dissect the neck. Focusing on the same image, we again concentrate on a major structure representing its own individual plane, the descending aorta. By definition, the descending aorta starts at the same level as the ascending aorta and ends at the T12 level where it enters the abdomen posterior to the diaphragm. Looking again at this image, in which we used to introduce the thoracic duct, you may notice additional prominent features. First and foremost is the ascus vein, which receives the drainage of the posterior intercostal veins from the right side of the thoracic wall. The venous content of the ascus vein travels superiorly, and the vein ultimately forms an arch that drains into the superior vena cava. Note the arch is located just superior to the right primary bronchus. Hence, this should give you an idea at which level in the mediastinum to find the arch of the esophagus. And by the way, esophagus means without a twin. What this means is that usually the posterior intercostal veins of the left side do not drain to an ascus vein per se, but drain to accessory hemiascus veins, which cross the midline to drain into the esophagus vein. It is these veins that cross the midline that are technically called the hemiascus veins, and there can be variations. Here, for example, there seems to be a prominent hemiascus vein that drains superiorly to the left brachiocephalic vein. Indeed, we have scoured the literature, and this particular variation on the hemiascus vein has not been reported previously. We are now at our last plane, the sympathetic trunk plane, that technically is not part of the mediastinum. Starting at the base of the neck, the sympathetic trunk runs the entire length of either side of the vertebral column, and sympathetic ganglia are found at every level. The thoracic splanchnic nerves are also found in this plane. The three thoracic splanchnic nerves are the greater, lesser, and least. They supply the abdominal viscera, not the thoracic viscera, and only the greater splanchnic nerves is illustrated in this image. We have now identified all the prominent structures of the thorax in the coronal planes. That is, we have shown how these structures extend from one compartment of the mediastinum to another. Now comes the fun part. Let's identify them in cross sections. Here we show the first cross section, and at what level is this cross section from? Well, I hope you can read the title and as well see the horizontal bar in the cartoon at left. Yes, we are at the superior mediastinum, but as a clinician, what telltale sign lets you know you are at the superior mediastinum? Correct, there's no heart. The heart only extends to the sternal angle. Consequently, we're above the sternal angle. Now, We need to address the structures that are obvious in this cross-section. First, remember how we demonstrated cross-sections in a conventional image. Hence, we have the right lung, the left lung, and anteriorly the manubrium. But now we must go back to our planes. First, we encounter the venous plane, and we label the right brachiocephalic vein. Posterior to the venous plane, we had the arterial plane. Remember these? The brachiocephalic, the left common carotid, and the left subclavian artery. Behind the arterial plane is the trachea, and posterior to the trachea is the esophagus. Now comes the identification of the same structures we recognize, but in CT images. On the left hand of the image, I'm showing you an actual heart in situ and the approximate plane of where the sections of the cadaver were taken. The cross-section is labeled precisely as we just studied in the previous slide. Let's now identify the structures in the CT image on the right. This patient received IV contrast to better visualize the vessels. The dark spaces will represent the lungs. In the venous plane, we see the right and left brachiocephalic veins. Next, we encounter the prominent arteries arising from the aortic arch, the brachiocephalic artery, the left common carotid artery, and the left subclavian artery. The clear circular area is the trachea, which is anterior to the esophagus. Compare the CT image to the cadaveric cross-section and confirm now the need to have gone through the exercise of first listing the thoracic structures in longitudinal fashion, followed by recognizing them in cadaveric cross-sections. This is how we learn how to interpret CT axial images. We now move a few levels down within the superior mediastinum. Why superior mediastinum? Do you see the heart? Again, we identify the first plane, the venous plane, and now label the superior vena cava to which the brachiocephalic veins drain. Next, we recognize that we are at the aortic arch. This plane is followed by the trachea and by the esophageal plane. If you look closely, you can also make out the thoracic duct, now on the left side of the cadaver. And finally, on the right side, we can discern the arch of the esophagus. We do the same exercise we did before with respect to the CT image and place it next to the labeled cross-section. The heart in situ is presented for reference. We now identify the superior vena cava, followed by the aortic arch. We again have the trachea and the esophagus. What about the thoracic duct and the azygos vein? The thoracic duct is sometimes difficult to image using CT. If the dye had not entered the azygos system of veins, it too will not be imaged using these conditions. We now move just a little lower on the superior mediastinum on the cadaveric cross sections. Let's start the labeling. Here we see the ascending aorta and just to its right, the superior vena cava. The right and left pulmonary arteries are now labeled. If you become disoriented, go back to the beginning of the presentation when these were shown in the coronal plane. We now see the right and left primary bronchi. The cartilage can be observed confirming their identity. What does this tell us about where the section was taken? Just below the sternal angle. Hence, we should still be able to see the esophagus and the thoracic duct. And now clearly the two ends of the arch of the esophagus. Finally, the ascending aorta makes its appearance. We now go to the CT image and identify the corresponding structures. Again, on the left side, we have the labeled cadaveric cross-section and the heart in situ demonstrating the level of the section. We start by labeling the ascending aorta, the superior vena cava, the pulmonary trunk, giving rise to the right and left pulmonary arteries, the empty right and left primary bronchi, the esophagus, the esophagus vein, and finally the descending aorta. We're now ready to move into the inferior mediastinum and examine the heart. But before we do, let me remind you how the heart chambers are arranged. More is in a cross orientation than what we are generally led to believe, that the atria are on top of the ventricles. On the left, I show a heart in situ, and on the right, I show the orientation of the chambers as they will appear in cross-section. The right ventricle will be anteriorly, whereas the left atria is located posteriorly. Let's look at an actual cross-section now. And here it is, not like in a drawing, but precisely how the chambers are located in a person in the anatomical position. The right atrium gives rise to the right border. The right ventricle is anteriorly positioned. The left ventricle makes up the left border, and the left atrium makes up the posterior border. The interventricular septum separates the right and left ventricles. The large opening in the center of the heart is nothing more than the ascending aorta. If we now zoom in on the mediastinum itself, we can identify the descending aorta, the esophagus, the esophagus vein, and what is that round circular vessel posterior to the esophagus? The thoracic duct, just as you predicted from your knowledge of the structures after having studied them in the coronal planes. We can now identify more esoteric structures in the image. For example, check out the anterior interventricular artery in the interventricular septum. And if you really want to impress, look at the internal thoracic artery traveling with its dual internal thoracic veins just deep to the clavicle. Moving right along to how we see the heart in CT images, here it is. On the left, we have the labeled cadaveric cross-section along with the heart in situ. On the right, we have the heart in CT images. We can identify the right atrium, the right ventricle, the left atrium, and the left ventricle. Prominent also is the descending aorta, the esophagus, and the esophagus vein. We are now at our last cadaveric cross-section in the mediastinum. The right atrium is evident, as is the right ventricle and the left ventricle. Why not observe the tricuspid valve between the right atrium and the right ventricle? If the knife cut is not precisely at the level of the valve, the distinct components of the valve will be missed. This is just an unfortunate artifact of looking at anatomy in cross sections. But there is a distinct interventricular septum, and posterior in the heart we find evidence for another vessel that is marked with a question mark. Can you guess the identity of this vessel? It is the coronary sinus. Yes, cross sections can and will be deceptive until you experience them. We now reach the last CT image and compare to the cadaveric cross section. Note that this patient was not administered IV contrast. As the cross section indicates to us, we can label the right atrium, the right ventricle, the left ventricle, and what is that dark channel entering the right atrium? The coronary sinus. This now brings us to the conclusion of how to make heads or tails of a cross section and then identify the corresponding structures in a CT image.